and you're...
Hi, everybody. It's Dr. E.J. Eric Johnson at Alta Bates Summit, and we're going to describe how to do a bedside echo in a pinch. You can notice I have the COVID-19 look going on here. So we're going to pretend we're in the emergency department or we're in the ICU, and you've been called upon to assess this patient's left ventricular function, and you go grab the echo machine. So we have a Sonosite echo machine here. This is the kind we have at the Summit emergency department. Slightly different unit up in our ICU, and everybody might be a little bit different, but I think this Sonosite that we're going to demonstrate today is the most common that we see around the region. So we'll switch our echo machine on, and that's probably the hardest part for these different echo machines, is finding the power button, okay? And then we need to know what probe we're going to use. So we want to use a cardiac probe, which looks like this, and sometimes it takes you looking at the actual machine and identifying the probe. You want to make sure it's this probe and not the linear vascular probe that we use for vascular access. So it's a little more narrow. And you can see where that's attached. Now this is a really nice unit, the Sonosite. We can actually go down here and you can select the transducer and exam type. So the first thing after it powers up is you hit select, and then you pick the cardiac probe, and it looks like it's already selected here. You can move this down if you need to, or select another one, but there's cardiac, and then you just hit the scan button and you should be ready to roll. So it's very simple with this Sonosite system. Okay, so we'll go ahead and begin scanning. This is our victim. This is a patient in shock, and I think it's important to understand that this isn't going to be like doing a formal echo, because the patient, you can rarely get them up in their left lateral position like you like them to be for the apical views and echo. So we're going to be usually doing this in a supine position. And remembering from the slides that we talked about earlier, you want to find the little dot on your probe, and that's going to be your marker for when you're imaging. To do parasternal views, we're going to be down here on the chest, about the third, fourth intercostal space adjacent to the sternum. And then for the apical views, we're going to be up around here at the point of maximal impulse, which is usually right below the nipple. But we're going to work with that and look around. So let's start off by just imaging in the parasternal view here, okay? And I've got my dot pointed towards the right shoulder, so that's going to give us the parasternal long axis view that we're all used to seeing with echo. And let's put the gain up a little bit. So looking at this, if I just shove this little slider over, we're going to get better view. That's the gain down there. The longitudinal axis or the vertical axis is actually the depth. So we can change that too. We can kind of come down and make it get more depth if we want it, or we can make the image bigger by decreasing the depth here on the vertical axis. Okay, so you can see my hands aren't that steady, but we get a nice view. This is an unusually great view of the parasternal long axis in this patient, who is obviously not in shock, but going to look a lot different if he is. So to get the next view, which is the short axis view, you just turn your transducer 90 degrees, and you have the dot now going towards the left shoulder, okay? And that gives you this nice image of the LV in short axis, the so-called donut view. It's right below the mitral valve in this case. If I come over, I can get down a little bit lower. And you can see that he's got nice symmetric LV contraction. And then if you just rotate up, sort of up by the, up more towards the top of the heart, you're going to start seeing the aortic valve come in. You can do all that. But you know, honestly, the main things from these views for us is going to be to assess LV function. Here we're getting a real good idea of that. So we take our transducer now, get a little bit more gel on it. Again, remembering where your dot is. very important, the dot goes to 3 o'clock when you come down here at the apical view, okay? So you're pointing down at about 3 o'clock, so it's, and then we just rotate up. I'm right below the nipple, and we got a nice view of his LV. We also can see his RV pretty well over there. At least I think I can see it pretty well. You know it's not at least some gigantic RV like you might see in acute pulmonary embolism, which is a huge help when you're in the ER. So you can see the kind of nice views we're getting. We know this patient does not have any LV dysfunction, so we've kind of taken shock off the table. Nice view of the mitral valve. In a moment, we'll show you the things we do to look for mitral regurgitation with color flow imaging, which I think will be helpful. Now, in this case, we could probably increase our depth a little bit so that we can see a little bit more of the left atrium. And we did that, and you can kind of see everything. I'm not getting exactly right angles, but the mitral valve looks pretty good. And then Elaine, I'm going to have you just put a little color in that if you would, and just maybe tell us how we do that. There's a little button over here on the side that says C.
So yeah, we hit the C. There's M for MO, D for Doppler, C for color. I just hit color. I with my finger moved the color bar over to the left atrium. You can see a little bit of trace.
Yeah, there's a little trace MR as we see in almost everybody, but there's certainly not wide open MR, which too bad we don't really actually have a shock patient who has wide open MR. But everybody knows what that looks like, at least the cardiologist in the audience. The last angle that we need to do or orientation is the subcostal view. So we find the xiphoid process and come about 2 centimeters below that. And then we kind of angle up, and you can start to see the heart, and we have pretty good depth from that last change we made. And there you see the RV really well. And then to look at the IVC, we just basically orient the probe 90 degrees, and it brings the IVC into view, which if it's really big is going to show up really nice. Take a little sniff there, Rob. And you can see his IVC is nice and normal. Just sniff, man. Breathe normally. Good. So all good. So there's your, and this is also a great view, as everybody knows, for pericardial effusion. We basically, that's the exam that we want. The last thing that we want to talk about is just acquisition of images. And Elaine, why don't you show us how to do that on this machine in case we want to do that?
So there's a button down here at the bottom of the screen that says Save Video Clip. You just hit that one time, and it will store the clip to the hard drive. If you have a still frame image, you can save an image that is still frame.
Okay, so we've got our images, and we're pretty much done. What I'd like to emphasize to everybody, because it's the thing that I'm going to forget, is where do you orient your transducer? Remember the dot on the top of the transducer. For peristernal, it's up towards the right shoulder for your initial long axis view, left shoulder for the short axis peristernal, 3 o'clock for apical views. So it's pointing right down at basically at the bed. And then you're just kind of moving around until you get an image in that general vicinity. It's a little different for everybody, but you can see. Now, if you really want to get fancy, you can orient it 90 degrees. The dot goes up towards the head, and you can get the apical 2 chamber, which is awfully hard to do in some people, but not in this patient. And you can get a pretty good image of the inferior wall if you're interested in that, as we can see here. So hope that helps. Hope the slide presentation helps, and maybe we can all become at least decent echocardiographers in the pinch now. Thank you for watching.